Hi everybody, my name is Danielle. In this video I would like to talk to you about the FINS program. This is a real program. It's actually where I've done my internship this semester, and I think it's actually really great because it's addressing a bit of an unmet need in our community. Without further ado, I'll get started. So the social problem. The social problem we have in this case, unfortunately, is suicide. To get kind of a picture of how big our problem is, according to this very major cross-national study, upon the billions of people living on this earth, millions have attempted suicide at one time. It's quite a few people. This program in particular would like to address patients in the emergency room primarily. This reason being is that the research says that this is where we can find most of our patients who are at risk of suicide. And these two very large-scale studies, 8% of the patients that are presenting to the emergency room with non-psychiatric problems. So these are our patients who are coming into the emergency room with chest pain, broken leg, cuts and scrapes, any physical conditions. 8% are going to have suicidal ideation. And this risk is not being noticed by clinicians for various reasons. It may be that our interventions are not working. Whatever we're doing right now is just not working to identify patients. Other reasons being is that patients are not telling us that they have suicidal ideation. And why is that? It's a couple of reasons actually. I won't be naming all of them, but to kind of give you an idea, they're afraid that disclosing the suicidal ideation will prolong hospitalization. They want to go home. They're shamed. They feel shame. They're humiliated. Sometimes they fear that telling people that they're suicidal can lead to incarceration or arrest. For our patients who are very serious about suicide and completing suicide, they're not disclosing it because they do not want to be rescued. Some patients do not want to relinquish firearms or drugs, especially if this leads to finding out that they've got them illegally. I could name, like I said, quite a few, but those are just a few reasons as why we have found that patients are not disclosing their thoughts of suicide. And so here we have the FINS program. So the FINS program is a 3-year federally funded grant. It was awarded to the University of Central Florida and University of South Florida to implement evidence-based strategies. Based on the literature, we've got a couple of solid strategies to identify patients in the emergency room who are at risk of suicide. These evidence-based strategies are also going to improve safety and suicide care post-discharge. So we want to have a continuous line of care for patients. This is what we're hoping is going to reduce our suicides. Patients are going to be followed by care coordinators. And basically what's going to happen is that their patients will receive suicide treatment and safety planning once they're discharged from the emergency room. And this program will also be connecting community resources, which is kind of my favorite part actually. It will be working with various agencies to provide consistency and suicide risks assessment. This will hopefully kind of bring everybody together and increase the awareness of how big our problem is of suicide. So our research question is, will adding these evidence-based interventions improve patient safety for suicide in the hospitals? Will it improve suicidal care? And it is hypothesized that the SPINS program will reduce suicide rates and increase community awareness of suicide prevention in the greater Orlando area. So the sample, who are we looking at for this program? This program will use non-probability sampling, and not everybody will have an equal chance of being enrolled into the program. Patients who come into the emergency room are given a PHQ-9 questionnaire. This questionnaire assesses for depression, and patients who are scoring a 10 or above will be flagged. That means the care coordination team will be notified and will go into the patient's room to assess for further assess for suicide risk. So the questionnaire, I'm sure many of you have seen it before, looks something like this. And on the bottom, you'll see the question that says, thoughts that you would be better off dead or better off dead or of hurting yourself in some way. Patients who are answering between a 1 and a 3 to this question are also flagged and deemed to be at a higher suicide risk. So that's one thing that we really like to watch out for. Patients who are scoring high or answering between that 1 and 3 on the I question for this questionnaire screening tool are then given another screening tool. This kind of is what is making our suicide assessment more formal and even kind of takes away any clinician fear that may impact the assessment. The way that you are asking a patient about suicidal ideation may change their answer, and so this will make things much more formal. You ask the first 2 questions verbatim, and then you go through the form as directed. If they answer yes to question 2, then you would go to the end. And these questions just ask about thoughts of killing yourself, thoughts of wishing you were dead and going to sleep and not waking up, or doing anything or starting to do anything to prepare to end your life. Now, these are very hard questions to ask for some people, and this form hopefully will make the screening process more thorough. Other factors that go into sampling are the presence of risk and warning factors. We really separated these out because patients who have risk factors don't always have as high of a risk for suicide. The presence of warning signs are a higher indication of suicide risk. This form kind of puts them all together to give you an overall general idea. And so asking patients these questions who are responding positively to the PHQ-9s and the CSSRS form that I just showed you, it increases that risk that we're looking patients who have a lot of check marks on this are at an increased risk. So history of trauma, as you can see, legal issues, mood disorders, hostility, access to lethal means are all some of our risk factors. And our warning signs, the things that are closer to the point of that attempt of suicide, making plans to hurt yourself, seeking access to means to hurt yourself, severe or overwhelming pain, withdrawal, changes in sleep, hopelessness. You can read, but this form is a very helpful tool in kind of determining how close is this patient to having suicidal thoughts or attempting suicide. One thing I also wanted to know about the sampling for this program is that patients who present to the emergency room with suicidal ideation are also included and considered eligible because they are presenting with suicidal thoughts. And that the enrollment into the program and the consideration for eligibility into the program is deemed by the care coordinator based on all of those assessment tools and based on the report of the patient. So the program design. In this program, we will be using a single system research design to evaluate our program outcomes. The timeline is shown here as our timeline for follow-up to be starting at 24 hours between 24 and 72 hours after discharge from the hospital. This is when patients are deemed to be at the highest risk of suicide, and so we want to catch them very shortly once they leave. After that, patients are going to be followed at weekly intervals up to 90 days or longer if deemed necessary, or even shorter if patients are greatly reducing their risk of suicide prior to the 90-day mark. And at these follow-ups, this is kind of a good idea of what we're going to be doing. This graphic will show you all of the assessments that will take place. So a care monitoring form is basically a form that we will use to kind of structure our interviews with patients about how they're coping, what kind of stressors they're having, and also to help link patients to community resources. We will be documenting how we are connecting patients to other agencies within the community. At these follow-ups, patients will receive PHQ-9 and CSSRS assessments again to gauge their level of depression and suicide risk. We'll review things such as the Wellness Toolbox, which gives patients a crisis action plan. In the time that they are noticing that they are beginning to feel in crisis and beginning to feel suicidal, patients will use this toolbox to reassess their coping skills and reassess their link to life, as we call it, what is keeping them alive. The Wellness Toolbox also includes a lot of contacts, phone numbers for resources such as the Suicide Prevention Hotline, family members that the patient has deemed able to help them in crisis. So that's a very helpful tool for our patients throughout their participation in the program. The suicide triage forms also are reassessed to gauge how many risk and warning factors the patients are having throughout the program. Our hope is that their protective factors will hopefully increase as they continue working with our care coordination team to reduce the risk of suicide. Primarily, we've got 3 measures for the outcomes of this program. We are measuring depression. As I said before, that's going to be measured through the PHQ-9. We'll want to see those scores decrease over time. The observation of suicide risk factors and warning signs. And I also should have put there in conjunction with protective factors, but that's going to be in relation to the triage form. We're hoping that risk factors and warning signs go down while protective factors go up. The number of patients who are screened and enrolled into the program will also be measured as an outcome. We're hoping that we're identifying the patients through these evidence-based interventions and assessment, and that we're catching everybody who is at risk. So that number will hopefully reflect the accurate amount of risk. So all in all, the social work implications and future directions that this program hopes to ignite is getting familiar with suicide prevention, engaging professionals in practice, and improving our interventions and connecting the community's resources. The trainings that this program offers hopefully will encourage professionals to be the lifelong learners we have been striving to be. We are not ever done learning, and so new research is always coming out and new evidence-based practices are always being learned. I think it's important that as practitioners we do practice. And also this program will connect the community. Our mutual understanding for how to identify suicide will only improve our treatment and those positive outcomes that we're looking for. So that is the end of my presentation. Thank you all for listening. I hope that what you've gathered from this is that the FINS program really has potential to help the community and to help save some lives, because suicide is very preventable and we can all prevent these unnecessary deaths that are increasingly happening. I have included here the Suicide Prevention Lifeline for anyone who wants to offer that to their patients. And also, I hope you have a good day. Thank you.